Hi everyone, we're back for Chapter 4, Callous Unemotional Traits and Developmental Pathways to the Disruptive Behavior Disorders. So our objectives for today, we're going to define CU traits, identify various ways to subtype disruptive behavior disorders, summarize studies that demonstrate stability of CU traits, understand the role parenting, personality traits, genetics, and neurocognitive deficits play in the development of CU traits, summarize the key points regarding the developmental model of CU traits, understand the role of brain structures as outlined in the cognitive neuroscience approach, and summarize the next steps for advancement in understanding the etiology of disruptive behavior disorders with CU traits. So the first thing that the book mentions is that it is a heterogeneous disorder. So disruptive behavior disorders manifest itself in many different ways. And there's many different correlates. So there's different sociological, social, biological, cognitive, and emotional correlates. So each student with an emotional behavioral disorder might have different social backgrounds, biological predispositions, cognitive abilities, and emotional issues. The severity of the disorder differs from student to student, and the treatment also differs from student to student. So when we think of callous unemotional traits, we typically think of like all those crime shows that we watch that talk about people who are sociopathic and psychopathic. And a lot of the CU traits are what characteristics make up a psychopath or a sociopath, so we are kind of familiar with them. They include lack of guilt, so people do things and they don't feel bad about it. Lack of empathy, they can't understand or take on the viewpoint of how other people are feeling. They have deficits in emotional responding, so if they see somebody who's upset or crying, they don't know the right way to respond. They have a disregard for others, so they don't care if their behavior hurts or harms anybody, and they're insensitive to punishment. They often don't change their behavior because punishment doesn't work. So if they get stuff taken away or they get grounded, it has no effect on their behavior. So there have been multiple past attempts to subtype disruptive behavior disorders to help study them more. So the first is age of onset, and typically they classify them as childhood or adolescent. And it's just classified according to which age the first severe behaviors appear. Childhood onset is more likely to show aggression in childhood and adolescence, and more likely to show antisocial and criminal activity into adulthood. They're more likely to show deficits in executive functioning and cognitive deficits. So the ability to make decisions, to plan, to judge, they have deficits in those. They show temperamental and personality risk factors such as impulsivity, attention deficits, and emotional regulation. They have greater levels of family instability and conflict. Their parents often have poor parenting skills. Childhood onset is more severe, and it has a chronic pattern of behavior that's related to dispositional factors and environment. So what that means is that children who have childhood onset disruptive behavior disorders, it's often caused by something that's in them, their temperament, their personality, their genetics, and environmental factors. The adolescent group is limited to problems in adolescence typically. They're less aggressive, but they're more rebellious and rejecting of conventional values. So it's often like that normal teen rebellion, just kind of a little bit kicked up a notch. These behaviors that they display in adolescence are not likely to last into adulthood. So it's not like this disorder, when it is adolescent onset, is something that's going to continue into adulthood like it is with childhood, but they may suffer the consequences of those choices that they make during adolescence, such as a criminal behavior or dropping out of school. So as we know from Chapter 1, where we went through kind of the current state of students with disruptive behavior disorders, there's a large number of students who drop out of school. And that's something that unfortunately is really difficult to do when you're in your teens, late teens and your early 20s. You can't go back to high school and get a diploma. You can get your GED, but there are limitations to having a GED and not a diploma. Another way that they've attempted to subtype it is comorbidity. So what other disorders are likely to be associated with disruptive behavior disorders? They often focus on attention deficit hyperactivity disorder because those children with ADHD and a disruptive behavior disorder often show more severe and aggressive patterns of antisocial behavior. They have poorer outcomes, they have higher delinquency rates, they have higher arrest rates. However, there's such a large number of students who have ADHD who also have disruptive behavior disorders that it's not really a good way to subtype them. There's just too many, so it's hard to get good research on those students who don't have ADHD comorbid with a disruptive behavior disorder. The next is the type of aggression, and there's two types of aggression that they focus on, reactive and proactive. Reactive aggression is often impulsive, but it's only in response to a threat or provocation. And they have an intense physiological reactivity. So they might start sweating, their heart rate is going to increase, all of those things that we see when we get nervous and angry in a typical developing student, we're going to see when there's reactive aggression. These students often respond hostilely or aggressive to an ambiguous situation. So if I were to go up to you and be like, hey, what's up? I'm not excited, I'm not angry, it's ambiguous. A student who has reactive aggression is going to take that as hostile. They have difficulty developing non-aggressive solutions to social problems. So if they get into conflict with a peer, the only thing that they really know how to do is to react with aggression. They have problem developing coping skills other than aggression for that. And reactive aggression is correlated with school adjustment problems and peer rejection. Obviously, if you hit your peers constantly every time there's a little bit of a tiff, they're not going to like you very much. Proactive aggression, on the other hand, is aggression in pursuit of a goal. It's premeditated and it's planned. Children who show proactive aggression have a tendency to overestimate the positive consequences of the aggressive behavior. So they're more likely to think that their aggression is going to end up in some tangible reward, and that's going to outweigh the negative consequence. In addition to that, they also underestimate the negative consequence. So they think that whatever they get is going to outweigh whatever consequence they have that's negative, and it's going to make up for it. This is correlated to delinquency and alcohol abuse as a teen and criminality as an adult. There is a correlation between both groups, reactive and proactive, and they tend to overlap, but it leads to the conclusion that there's higher aggression that have both reactive and proactive aggression, and there's a less aggressive group that has only a reactive aggression. So this is a good way to subtype students with disruptive behavior disorders. And the last attempt to subtype is the construct of psychopathy. So these are antisocial traits, which is the lack of regard for others, violating the rights of others, deceitful behavior, truancy, running away. Affective traits such as the lack of empathy, the lack of guilt, shallow emotions, and interpersonal factors, egocentricity, so thinking everything's about them, callousness for personal gain, so they don't care what they have to do as long as they can get some gain from it. And the combination of those three, the antisocial traits, the affective traits, and the interpersonal factors, show a more severe, violent, and chronic pattern of antisocial behavior. Students who have these three also tend to show affective, cognitive, and neurobiological characteristics. One way that they demonstrated this construct was by what they call undersocialized. And undersocialized in the DSM was defined as failure to establish a normal degree of affection, empathy, or bonds with others, or a lack of peer relationships. When they also don't help others unless they can gain from it, and they often manipulate others. So if you're familiar with working with students with emotional impairments, that kind of describes them to a T. However, outside of the school setting, it's a little bit harder to kind of quantify what exactly it means by undersocialized, because typically when people hear the words under-socialized, they think that they just aren't around enough children when they're younger and that it's a result of poor parenting. In addition to the thinking that that's poor parenting because of that poor terminology, it only included one characteristic of affective or interpersonal domain, and for these reasons it's not used. However, there is research that shows that those who are aggressive and under-socialized have poor adjustment and continue this behavior into adulthood. They also have neuropsychological correlates such as low serotonin. So this is something that, while it's not necessarily a useful subtype, those who are under-socialized do have some important useful aspects for research purposes. Another important aspect to look at is the stability of the CU traits in adolescents and children. So how far across the lifespan does it continue? So when we're talking stability trait, we're talking 0 to 1. So CU traits from childhood to early adolescence are pretty stable, with an estimate of 0.71 for 10 to 14-year-olds. So that's pretty high. 0.55 for 4 to 9-year-olds and 0.5 for a 9-year period. That again, those are both still pretty high numbers. And another study also found 0.71 for 13-year-olds. There is stability from adolescence into adulthood. 0.43 for girls and 0.54 for boys aged 16 to 19. They found 0.6 for 17 to 24-year-olds, 0.4 from 16 to 18-year-olds. And they do have some moderate stability from childhood all the way into adulthood. So they have found the stability estimate as 0.31 for the age span of 13 to 24. And they found that children at the age of 13 in the upper 10% of CU traits were 3.22 times more likely to be elevated in those traits 11 years later. However, only 21% of boys showing their CU traits diminish over time. So let's talk quantitative and qualitative reviews of CU traits. So there's a bunch of different studies that we're going to talk about. The first is Edens et al. Edens did a qualitative meta-analysis of 21 studies, and they found that CU traits were associated with general recidivism at a rate of 0.24 and violent recidivism at a rate of 0.25. Remember, it goes from 0 to 1. And recidivism means likelihood of committing the same action or crime. Frick and Dickens did a qualitative review of 24 studies. 10 showed an association between CU traits and aggression, antisocial, or delinquent behavior. 14 showed a predictive relationship for the duration of either 6 months to 10 years. Frick and White did a study where they reviewed 8 concurrent studies and 3 longitudinal studies. They showed an association between CU traits and the severity of antisocial behavior. They concluded that children and adolescents with CU traits had a more severe and pervasive pattern of aggressive behavior, and that aggression is more premeditated and instrumental. So it's more that proactive aggression instead of that reactive aggression. Frick and Dickens did a study where they looked at 5 studies, and they showed that children with CU traits were associated with poorer treatment outcomes. Clinic-referred boys with conduct problems and CU traits were less responsive to parenting interventions with boys. The group with and without CU traits responded to intervention that focused on teaching parents methods of using positive reinforcement to encourage pro-social behavior. So pro-social behavior is that giving instead of giving just to give and help instead of expecting something in return. They did find that only the group without CU traits responded to intervention, teaching more effective discipline strategies to parents. Washbus showed that children with conduct problems and CU traits responded less well to behavior therapy alone, but it improved with stimulant medication. So this makes sense. We did talk on the previous slide about the fact that children with disruptive behavior disorders have a high rate of comorbidity of ADHD, and ADHD is often treated with stimulant medication. And Caldwell showed that CU traits improved when using an intensive treatment program that utilized reward-orienting approaches that targeted the self-interest of teens and taught empathy. These teens were less likely to recidivate. And we're going to talk in a couple of slides about the reward pathway and reinforcement and punishment. So then the book goes back to CU traits and past subtyping attempts. So let's revisit these. Age of onset. As we know, childhood onset are more likely to have CU traits, and there is a predictive value. Having CU traits predicts the likelihood of being a violent offender, and different correlates than childhood onset conduct problems that don't have CU traits. So there are different correlates we talked about on the first slide, such as social, biological, cognitive, and emotional correlates. Comorbidity and ADHD. Conduct disorder and ADHD and CU traits have the most severe behavior problems and the most stable pattern of those problems. They often show the same genetic, emotional, and cognitive correlates as adults who have psychopathology. They've shown that levels of fear and reward dominant response styles are very similar to those of adults with psychopathology. And we talked, I think in one of the previous chapters, about the fact that children with disruptive behavior disorders have a low level of fear, so they're constantly seeking new novel stimuli, or they're thrill seeking to kind of kickstart the fact that they don't have a whole lot of input coming into them. Types of aggression. There are social cognitive deficits, specifically deficits that emphasize rewarding aspects of aggression while ignoring punishment. So people who have disruptive behavior disorders, psychopathology, sociopathy, they often find pleasure in aggression, and they don't necessarily have that guilt and remorse that most people do when they display aggression. They also have emotional characteristics that are associated with proactive aggression, specifically those associated with CU traits, such as the lack of emotional responsiveness to provocation. So often children with CU traits, when they're provoked, they just react with aggression, but they don't have that emotional reaction as well. Most of us would get angry or upset or cry. They don't have that. And conclusions. So childhood onset, high rates of ADHD, and both proactive and reactive aggression show the worst pathway and the worst chronic pattern behavior of disruptive behavior disorders. CU traits, antisocial behavior, and parenting. So there are some parental failures that are linked to disruptive behavior disorders, the failure to socialize, and ineffective parenting strategies. However, there are differences for children with and without CU traits. So dysfunctional parenting practices such as low parental involvement, not using positive reinforcement, poor monitoring and supervision of children, inconsistent and harsh discipline are correlated for disruptive behavior disorders without CU traits, but there is no correlation to those with disruptive behavior disorders with CU traits. So it kind of makes you think that parental practices really don't have an effect at all on those with CU traits, which makes sense because, as we mentioned in the previous slides, they're less sensitive to punishment. There are some antisocial behavior and personality traits that are linked to those with CU traits. Being fearless, so not thinking that anything is going to happen to you, you're not going to get harmed, you're invincible. Thrill seeking, so those children who have some difficulty getting stimuli or reacting to stimuli, they often thrill seek, so they might have behaviors that are more dangerous. Low anxiety, they're less distressed by their behavior. So the fact that they're making people upset, that they're manipulating people, it doesn't bother them. And neuroticism. And neuroticism is defined as emotional instability, and they have low neuroticism. So they don't have that back and forth of, oh, I'm really upset, oh no, I'm okay. They're pretty much stable in their emotions, and it's pretty much that they're emotionless. CU traits and genetics. So there is some heritability to CU traits. Some studies estimate it between 42 to 43%. Other studies estimate it at 68%. However, there is a correlation independent of aggression, and those people who display antisocial behavior traits with CU traits have an heritability rate of 0.81. And there are some brain structures that are specifically targeted when we're looking at heritability in CU traits. The left posterior cingulate and the right dorsal anterior cingulate are more heritable. The left posterior cingulate is 0.46 and the right dorsal anterior cingulate is 0.37. And there are also common genes that explain the phenotype relationship between these regions and psychopathic traits. So there is a link between these regions in the brains and that phenotype, that actual behavior that we see being exhibited. So let's talk CU traits and neurocognitive impairments. So there's two main areas that we're going to talk about: attention to fear and reinforcement and punishment. For children who have CU traits, they have reduced autonomic responses to the distress of others. So our autonomic response are those things that we talked about a couple of slides ago. So our heart starts to beat fast, we might start sweating, all of those types of things that happen when we're nervous. We have those reactions when others are in distress, but children with CU traits don't have those. They have reduced cognition of fearful and sad facial expressions, so they don't recognize fear and sadness on other people's faces. They also don't recognize fearful vocal tones, so if somebody is upset or they're angry, think about when you're trying to not act angry in the way your tone of voice sounds. They don't recognize that. They're not able to pick that up. They have reduced attentional orienting to distress cues. So if somebody's distressed, if we think about the ways that we know that they're distressed, so they might be fidgeting, they might have a look on their face, they might be pacing. Children with CU traits can't pick up on these. However, if they focus on the eye region of the person who is having that reaction, it does increase their ability to pick up on those expressions of emotions. The way that they found this is that they found that children with CU traits have a reduction in the number and the duration of the fixation on the eye region when processing fearful expressions. So if we think about it, when somebody is mad or upset, we often pay attention to their face and their eyes specifically. Children with CU traits don't. And then the next is reinforcement and punishment. Children with CU traits have a problem with extinction. And we talked about extinction, I think, in the last chapter. And we go back to Pavlov, remember? So you had the food that was paired with the tone, and then the dog salivated. And they did that over and over again until the tone alone produced that salivation. Well, if they just keep producing the tone and it's never paired with the meat again, then eventually the dogs are going to stop salivating at the tone. Children with CU traits don't have that. They still continue that conditioned response even after there's no association. And they have trouble stopping a previously rewarded response after that response was associated with punishment. So once something is associated with punishment, they can't stop doing it. So they do a behavior, it results in punishment, they just continue to do it. And again, it's because, we talked about earlier, they're very insensitive to punishment. They also have an impairment in reversal learning, in which they had to reverse the response that's associated with a stimulus following a change in reinforcement. So if something was positively reinforced or negatively reinforced, and then either positively punished or negatively punished, they have a problem changing their response after there's a difference in that contingency, once it changes from punishment to reinforcement or vice versa. However, they're not unresponsive to punishment like previously thought. When given a task, if they're punished, they're just as likely as a typical peer to choose the alternate situation in their next task. However, they revert to the old behavior even if it's not reinforced. They're more likely to do it actually following a behavior that is rewarded. So they have a bad behavior, and then they do a behavior that's good and they get rewarded. They're actually more likely to revert to that bad behavior that wasn't rewarded. And the reason is because they have the inability to maintain behavior in their orbitofrontal cortex. So it shows that the orbitofrontal cortex, which remember is our executive functioning center, it's what makes us us, the ability to make good decisions, that's impaired in children with CU traits. Okay, so let's talk developmental models of CU traits. Sorry, my back button doesn't work on my laptop, so if I accidentally hit it, I gotta go all the way through to get back to this slide. So there are developmental models of CU traits. There's not many that are very valid. So when the chapter talks about it, it talks about the items that these models need to include. And the first is the normal development of guilt and empathy. So these models need to include the typical way that guilt and empathy form in children. The next is temperament. They found that behaviorally uninhibited and fearless children seek out novel and dangerous activities. They show less physiological arousal to threats of punishment, so they don't get scared, their heart doesn't start to beat, they don't start sweating. They also score lower on measures of conscience development. And let's talk about conscious development. There's three main areas that we need to talk about. The first is deviation anxiety. Deviation anxiety is the anxiety and the discomforting arousal that's present after we've done something wrong. This develops an internal system that inhibits that misbehavior. So if we feel bad about something, we have that arousal in us that we don't like, so we're not going to do it again. But those with CU traits don't have this deviation anxiety. And the fact that they don't have this deviation anxiety impedes their conscious development. Scores on measures of fearlessness correlates to measures of CU traits. So if they're high on fearlessness, they're also probably going to be high on CU traits. Empathetic concern, we're biologically prepared to respond to the distress in others. And there's an area in our brain called the violence inhibition mechanism. And in that mechanism, we have an autonomic activity increase when we see somebody else in distress. This develops before we're actually able to take on the perspective of others. So think of a little kid who sees a little kid crying. They don't know why they're crying, but they just cry in sympathy. The child associates distressing behaviors in others and doesn't carry out these behaviors, that behavioral inhibition, where we learn not to do it. And they don't do it because they don't like that negative arousal that they feel. Children with CU traits don't have that negative arousal, so they never learn to inhibit that behavior. And the last is parenting. Secure attachment predicts the development of conscience in children who were fearless. So even though they might be high on that fearless, having a secure attachment to a parent kind of ameliorates that. Uninhibited children showed guilt only when parental consistency was high. Authoritarian parenting, which is that really strict parenting that often uses corporal punishment or physical punishment, and you have no warmth with the child, this had no effect on uninhibited children. And if we think about it, as we've said in previous slides, they're really insensitive to punishment. So that's not going to work on children who have CU traits. In talking developmental models, we do have to talk about developmental models for children that have childhood onset conduct problems without CU traits. Anxiety is an important one. People with high rates of anxiety don't have problems showing guilt or empathy, and they're often distressed by the effects that their behavior has on others. Those who show high levels of impulsivity often have deficits in verbal intelligence. They have a hostile attribution bias in society where they perceive all ambiguous situations as hostile. Dysfunctional parenting most often shows itself in the form of inconsistent discipline, absent parenting, or lack of attention. Aggression, those without CU traits are less likely to be aggressive and only show reactive, not proactive aggression. And emotional stimuli, those without CU traits are highly reactive to emotional stimuli. So they have that emotional reaction to things that those with CU traits often don't have. So let's talk about cognitive neuroscience approach. A cognitive neuroscience approach helps to explain which neurological phenotypes may be inherited and lead to the temperamental style that places a child at risk for developing CU traits. It's concerned with functional neural architecture, and it provides an account of how computational processes in our brain are disrupted within a specific neural system and how that gives rise to disruptive behavior disorders. So there's three main structures that we're going to talk about. The first is the amygdala, and remember, amygdala is our emotional regulation center, specifically fear and aggression. Lesions on the amygdala show selective impairment for recognition of fearful expressions. So we talked about those with CU traits have difficulty telling when a facial expression is fearful. This is shown in functioning MRI studies as the amygdala responses are reduced. It also shows that there's an impaired stimulus reinforcement learning. So we talked about this in the previous slide where they have difficulty maintaining that rewarded behavior. They often revert back to behaviors that result in punishment and that aren't reinforced. The orbitofrontal cortex, if we have lesions in these areas, it shows impairment in extinction and reversal learning, which we talked about in the previous slide. That's two major problems that children with CU traits have. And decision making. Remember, our frontal cortex is our executive functioning center. Functioning MRIs show atypical orbitofrontal cortex responses during reversal learning and during simple decision-making tasks. So it shows that our decision-making is impaired if that area is damaged. They have impaired representation of reinforcement information and prediction error signaling. So let's talk about prediction error signaling. This is important for the caudate. So this area is important for prediction errors, and a prediction error is when you expect a level of reinforcement that's not received. Unexpected rewards are associated with positive prediction and caudate activity. Unexpected punishment is associated with negative prediction and decreased caudate activity. Those with CU traits show dysfunctional caudate signaling of both types of errors. Prediction signaling is important for rapid learning, and it may exacerbate problems with deficits in stimulus reinforcement that's caused by the amygdala. So those two areas just kind of have like the cyclical effect on each other, where one causes a problem in the other, which then causes a problem in the other. So the chapter ends with critical next step for major advances. The first is early screening. It's important to look at those who are at risk for developing CU traits due to temperament and biological factors. Treatment studies. We need to help tailor interventions to specific needs of those with CU traits. There's two specific treatments for those with antisocial behavior that work, the multisystematic therapy and the functional family therapy. However, these have not been tested on children with CU traits. We need better diagnostic tools. Most measures, such as the checklists and the rating scales, only have a limited number of items that assess CU traits. Most of them have very few, limited to 4 to 6 items. We need to have more experimental studies. They need to look at what combination of assessment techniques and formats are best in those diagnostic tools to accurately predict who's going to develop CU traits. And then we need the addition of CU traits to current diagnostic criteria. So we need to add a subset of CU traits for those with conduct disorder, as well as having the conduct disorder that we have now that is diagnosed for those without CU traits. The ability to have that diagnostic criteria is going to provide better all diagnosis, screening tools, and treatment. Let me know if you guys have any questions about this. If not, I'll see you for next week's lecture.